So just to complete the picture in relation to the publications regarding the trials of prophylactic therapy, the third trial was written up in RLIT 5093. Transfusion requirements of adolescents with severe haemophilia A, Arenstam, McClellan and Turk. I'm not going to go to it in any great detail, but if we look at the bottom of this page, right-hand side under the heading Patients and Methods, we can just see it says 75 boys without inhibitors and with haemophilia A were studied during the years 73 to 77. And then the next paragraph talks about the third trial, so prophylactic factor 8 given to 15 boys for limited periods during 1976 and 1977. Prophylaxis administered twice weekly to 5 boys during 76, 3 times weekly to 13 boys during 76 and 77. And then the publication clarifies what products were used. So bottom of the page, each transfusion was of cryoprecipitate, NHS factor 8 concentrate or commercial factor 8 concentrate, and was recorded as a single transfusion irrespective of dose. I don't think this document tells us which commercial concentrates were used, so we may need to fall back upon what was said in the earlier documents in that regard. So that's the third trial of prophylactic treatment. There's one further document I'd like to refer to on that, but we haven't yet got it available for screening, so I'll come back to that. I'm going to move then to one of the other major areas of study and research, which was the hepatitis study. It was often referred to as such, but in fact it probably better regarded as a series of studies carried out over a number of years. If we go to HHFT 5053_001, we can see this is entitled The Incidence of Australia Antigen and Antibody in Boys Suffering from Coagulation Disorders, report of a study at the Lord Mayor Treloar College, and it's authored by Dr. Rainsford and Dr. Cossart. And it tells us that each year as many as 50 of the disabled boys attending Lord Mayor Treloar School are suffering from haemophilia or other coagulation defects. This concentration in one residential centre of patients needing repeated transfusions has provided a good opportunity to study the incidence of Australia antigen and antibody in a vulnerable group. You'll note the words they used. The original plan was to follow the pattern of antigen and antibody in the boys and to relate these findings to clinical illness, frequency of transfusion, and the presence of Australia antigen in the blood and blood products with which they were treated. It was hoped to test the boys each term and to test an aliquot of the blood or pool of blood products given in each transfusion, and then reference to various tests. The study has continued for 10 terms, summer 1970 to summer 1973. 81 boys have come under observation, 71 haemophiliacs, 11 with inhibitors, 7 with Christmas disease, 2 with von Willebrand and 1 with aplastic anemia. 20 have been at the college throughout the study, but it has not been possible to examine the blood of every boy every term because of hospital admissions. The collection of samples from boys needing very frequent transfusion has been difficult because it was thought undesirable to test sera obtained less than a week after transfusion. And then we can see reference in the top half of the page to, in one particular period of time, examining the transfusion samples. And then it's recorded in the next paragraph that since the spring term 71, the Wessex Regional Transfusion Centre was screening all donors supplying material for the treatment of these boys, so screening for Australia antigen. There's then a reference to the results in terms of antigen, the position of 3 boys described. In relation to antibody, again, there's a description of the antibody results. If we go to the next page, bottom half of the page, there's a heading, Relation of Australia Antigen and Antibody to Hepatitis, and there's references to some attacks of hepatitis and jaundice. And if we go over the page, We can just see the summary and conclusions. 3 of the 81 boys with coagulation defects were Australia antigen positive at some time during the survey. 1 was a persistent carrier. 35 to 40% of the boys were antibody positive at all stages of the study. As antibody is evidence of previous exposure to serum hepatitis, it probably also indicates immunity. It's not surprising that clinical hepatitis is uncommon in adult haemophiliacs. Although the amount of antigenic stimulus in the transfusions given after screening began was less than before, it is still significant. And then we're told that only 12 of the 81 boys had suffered clinical attacks of hepatitis, although most had frequently been transfused since infancy. It would seem that exposure to antigen-positive blood in childhood is likely to be followed by subclinical infection, whereas in adult life the clinical attack rate is about 50%. None of the 4 cases of clinical hepatitis occurring during the study were antigen positive. This may be compared with the figure of 30 to 40% for post-transfusion hepatitis generally during this period. So it's undated, but it's obviously written after the conclusion of the 10 terms, so at some point after the summer of 1973. There's actually a more detailed interim report. I'm not going to go through it in any detail, but it's at HHFT 40332. So we can see it's the same authors, but it's headed interim report. And if we just go to the second page, we have a description of the aim of the study: to follow the pattern of serum hepatitis antibody and antigen in boys suffering from haemophilia and closely allied disorders resident at the college, to see how these patterns correlated with clinical illness, frequency of transfusion, and with the presence of serum hepatitis antigen in the blood and blood products with which they were treated. And then it said it was hoped that some of the boys might provide serum, which would be useful as a diagnostic reagent. Whether that was known, that was being done, is unclear. There's a description under the next heading of the number of boys studied. So this is in the interim stage from summer 1970 to autumn 71. At that stage, 54 boys had come under observation. And then there are findings in relation to serum hepatitis antigen and antibody. If we go to the 5th page, there's a heading hepatitis. Again, I'm not going to go through the detail of the facts and figures, but it records that of the 53 boys concerned with these investigations, only 6 have a definite history of jaundice. And then reference to 3 of those cases contracted the disease when at the college, the remaining 3 prior to entry. And then there are various tables. If we go to the next page. So there are tables in terms of showing the incidence of serum hepatitis antibody. Next page is a table with the analysis of cases with antibody. If we go to the next page, a table showing serum hepatitis antibody in the sera of boys suffering from coagulation disorders at Lord Mayor Treloar's. And then the remaining 2 tables deal with patients with inhibitors and Christmas disease. So that's just really to give a flavour of the study. So that's one of the early hepatitis studies that was undertaken at the college.
Can you help at all with, if you go back to the previous document, I think it's 001, 53, HHFT 5053 underscore 001. And go to the through it, please. Next page. Next page. Next page. And then the next page. What I'm looking for is there's the reference somewhere in there to there being a number of cases of post-transfusion hepatitis not associated with the administration of necessarily the disease. and I just wonder what justified it, but it's difficult to find it. But I can raise it. I'll raise it with you later.
Yes. I'll have a look at the document again and see if there's an answer to the question, sir. So we see that there's work being undertaken by Dr. Rainsford in relation to studying for the incidence of hepatitis in the early part of the 1970s. There is then further work undertaken by Dr. Kirk in the mid-70s. If we look at CBLA 40312, this is a document produced by Dr. Kirk in September of 1975, and it's a protocol for a prospective study of hepatitis and haemophilia associated with the use of factor VIII concentrates. If we look at the introduction, it says the transfusion of blood or its derivatives has been linked with the transmission of viral hepatitis for many years. And then there's reference to the hepatitis B. And at the end of that paragraph, it says this failure to prevent post-transfusion hepatitis may be explained by the following hypotheses. And if we look at A, B, and C, A is that current methods of detecting hepatitis B antigen are still not sensitive enough. B is that other known viral agents are responsible, e.g. hepatitis A, EB virus, cytomegalovirus. And then C, that other as yet unknown viruses cause a significant amount of post-transfusion hepatitis, which is supported by the recent work of Feinstein et al. So a recognition there that there is something other than hepatitis B, essentially, causing post-transfusion hepatitis. And then if we look at the next paragraph, it says the introduction of large pool factor concentrates into the routine management of haemophiliacs has revolutionised their treatment. And then there are further observations made in that regard, including the introduction of home therapy. And then halfway down that paragraph, a sentence beginning, however, treatment with factor VIII concentrates does expose the patient to a much larger risk of contracting transfusion hepatitis, since the fractionated product is processed from donor pools. Furthermore, commercial factor VIII concentrates are made from very large pools of some 2,000 to 6,000 litres of plasma from paid donors. An outbreak of both non-B hepatitis and B hepatitis associated with concentrates of this type has recently been reported by Krask et al. There's then a reference to Prince's publication and the suggestion that recipients of all commercial blood have a 10-fold higher risk of developing non-B post-transfusion hepatitis than recipients of all volunteer donor blood. And then Dr. Kirk says this, for these reasons, it is proposed to conduct a prospective study of hepatitis in order that the following question will be answered. Does the administration of factor VIII concentrates to haemophiliacs on regular replacement therapy significantly increase the incidence of transfusion hepatitis? So that's the purpose of the study, to look at the relationship between regular treatment with concentrates and transfusion hepatitis. And then Dr. Kirk says it's hoped that some additional points will emerge. A, any difference in the attack rates between commercial factor VIII concentrates and home-produced concentrates, namely Oxford and Elstree. B, the assessment of the value of a positive hepatitis B antibody test and the protection of the patient from the development of hepatitis. C, further information on hepatitis due to unknown viruses or agents other than hepatitis A, B, EB or cytomegalovirus. And then D is about the role of radioimmunoassay testing for hepatitis B antigen. So it is hoped that this will provide insight into and contribute to the knowledge of the other causes of post-transfusion hepatitis, essentially non-A, non-B hepatitis. We can then see reference to the method. There's reference to 3 centres having agreed to cooperate, Treloar's, Newcastle and Oxford Haemophilia Centre, and we've got the numbers there. And we'll see what this currently envisages is 20 patients from Alton, so from Treloar's on cryo, 10 on cryobuline, 5 on Elstree products. And then Newcastle will be solely haemophil, Oxford a mix of haemophil and Oxford factor VIII concentrate. And then if we look at the text underneath that, about halfway down that paragraph, each patient will be treated with the same type of material throughout the study, and where possible, batches should be arranged sequentially in order that the patient may receive the same batch of his particular brand over a period of 3 months. This will be difficult to achieve, and the cooperation of the manufacturers has been sought in making large batches available. So again, just pausing there, it shows an awareness of a policy of limiting exposure to hepatitis, limiting exposure to multiple donors by adhering to one type of concentrate, and as far as possible, limiting exposure to batches of that concentrate. But this is only being contemplated for the purposes of the study, rather than put into effect as a broader approach to the treatment of all pupils at Treloar's. And we'll see that expressly acknowledged to some extent on the following page. But before we do that, if we look at the eligibility criteria, so all patients with classic haemophilia on regular replacement therapy are eligible for inclusion, and then there's an exclusion for patients for whom major surgical procedures are planned. C, in the case of the Alton group, Lord Mayor Treloar College boys must be able to complete 3 academic terms. D is a reference to a preference for normal liver function at the point of entry into the study. And then E must be a minimum of 18 months. So each patient must remain on the allotted therapeutic material for a minimum time of 18 months. In the case of the college boys, arrangements will be made with their home centres that the allotted material is available for treatment during the vacation. So again, it appears to be practicable to maintain a patient for the purposes of the study on the same concentrate for 18 months. But as we've observed throughout the course of the week, there's no attempt to achieve that. It would appear outside the scope of the study.
You could manage that with concentrate. You couldn't manage it quite so easily with cryoprecipitate, could you?
In what sense, sir?
Well, the idea of the concentrate is to stick to the same brand in the same batch. That's possible because it's freeze-dried, transportable. A cryoprecipitate is made on site. Generally, it's not so transportable. It may simply be that cryoprecipitate of its nature comes from a limited number of donors anyway, so you could never have the same batch, in effect.
I'd read it in the latter respect.
But you'd have a different population giving rise to the plasma.
As between the home centre and the and Treloar's, yes, that's correct.
So you'd have Manchester, Newcastle, Leeds, London, cryoprecipitate finding its way through to Treloar's.
Yes.
If anything, you'd think that would increase the chances of there being some infection in the supply.
For those treated solely with cryoprecipitate for that period of time, perhaps, yes. Compared to treatment, I mean, obviously not necessarily compared to treatment with concentrates, but compared to treatment with local cryoprecipitate for an 18-month period, yes.
It's an internal one sort of cryoprecipitate and another.
And then the top of the next page talks about informed consent. All patients or their parents/guardians must give their informed consent. The following points will be made clear. 1, by limiting the transfused material to one type, the degree of donor exposure should be decreased. So an express recognition there of the advantages in safety terms of limiting transfused material to one type. And then it said that patients or parents should also be told that it will be necessary for blood samples to be taken at fortnightly intervals. The next heading in this protocol is procedure. I don't need to go through the detail of that, save to note that the second paragraph down refers to the taking of blood samples on a regular basis and tested for bilirubin, SGOT, etc. If we go further down, data recording refers to data being sent to Dr. Cossart at Colindale and also shared with Dr. Kirk. And then under the heading illness, if a patient develops symptoms suggestive of hepatitis, Form C3 should be completed. That's a procedure that should also be followed if the liver function test suggests hepatitis. And then there's a reference to the outbreak of non-B hepatitis at Treloar's the previous year, so in 1974, where it said it was found the period of illness and abnormal liver function tests was relatively short, and then it says, should a patient become ill, it will be necessary for serial blood samples to be taken for LFTs, perhaps twice weekly, depending on the clinical status of the patient. Bottom of the page refers to arrangements during the holidays. So Lord Mayor Treloar College boys require special arrangements for their treatment during the Christmas, Easter and summer vacations to ensure continuity of therapy. College boys on concentrates have been selected from the following centres only: Oxford, Royal Free and Newcastle. Arrangements are being made with these centres that the boys receive only the therapeutic material to which they've been allotted. Those boys on cryoprecipitate have been selected from treatment centres where only this material is available. And then if we go to the third paragraph on that page, commercial manufacturers, viz. Travanol laboratories and serological products, have agreed to reserve large batches of concentrates for this study. The directors or their deputies will be responsible for ensuring that a patient receives only his allotted material for a period of 18 months after entry. Batches should be arranged so that an individual receives preferably only one batch over a 3-month period. And then there are references to testing analysis, possible future extension of the study. It said it's proposed to acquaint the UK Haemophilia Centre directors with the pilot study at the meeting in September 1975, and those are the minutes of the meeting that we looked at before lunch. And then bottom of the page, although this is in principle a simple study, the operation and organisation of batches of material will present some problems. However, the actual units of factor VIII used will be no greater than in the normal day-to-day treatment, and the study may indeed be viewed as a rationalisation of replacement therapy, since the probable donor exposure to each participant should be less than that experienced prior to his entry to this study. So it's essentially being said that this, I'm paraphrasing clearly, but this is a benign thing for participants because their donor exposure is going to be reduced. What it doesn't explain is why, if that's the understanding, that's not the broad approach to therapy at Treloar's in any event. That's the protocol produced by Dr. Kirk in September 1975. And as I say, I won't go back to the discussion that was then held a few days later at the Haemophilia Centre Directors meeting about the study. There's a subsequent document, which I'm going to go to later, so I won't go to it now, but what it shows, in fact, in relation to Treloar's boys, 21 boys restricted to cryoprecipitate for the study, 8 cryopulin, 6 haemophil, 1 prophylate, 4 given Elstree concentrate, and 5 factor IX. There is some evidence of consent being sought, interaction with parents. And so, although it's not clear what information has been provided to elicit the consent, but we've just got a handful of examples of documents. So if we look first of all at TREL 40225_048. We can see a letter from Dr. Kirk, December 1975. We looked, I think, at a very similar letter earlier in the week, saying, in view of the problems of hepatitis and haemophilia, I've been asked by Dr. Rosemary Biggs of the Oxford Haemophilia Centre to conduct a survey on this subject. Whether that's, assuming this relates to the same study, whether that's an entirely accurate way of describing a study set up and authored by Dr. Kirk it may be questionable. Your son has been selected to receive only cryo when he requires transfusing. By limiting him to this type of factor VIII containing material, it will be easier to trace the source should he contract hepatitis. If you have any queries concerning this survey, I'll be happy to discuss the matter with you. So that appears to be the information that was provided, at least on this occasion, to a parent. It looks like it's a fairly standard form document. It's dear and then blank. And then there's some correspondence which shows discussions between Dr. Kirk and the Home Haemophilia Centre in relation to this study. So we can, again, look at some examples. TREL 40280_074. This is Dr. Mann at Birmingham Children's Hospital to Dr. Kirk in September 1975. Second paragraph, we'd be pleased to help in your study do in fact use cryoprecipitate for our haemophiliacs with one or two rare exceptions. And then refers to two patients and then says, last paragraph, please could you let me know when you wish to start this study. The quantities of blood which you will be removing will be quite large, and I wonder whether you'd thought of giving iron therapy too, is the question posed. So there's a interaction with the home haemophilia clinician, but doesn't tell us what, if anything, has been said to the patient or the patient's parents in that regard. TREL 40211_022. Is a little later on, April 1977, but we can see from the last sentence it's concerned with the hepatitis trial. This is from Dr. Swinburne to Dr. Kirk in relation to a particular patient, saying that she's given him cryobulin, and saying in the last paragraph, I'm sorry if this will interfere with your hepatitis trial. So again, obviously knowledge from the home haemophilia clinician of the trial, but doesn't tell us what was known by the patient or pupil. And if we go to TREL 40103_018, we've got a letter here from April 1976 from Dr. Kirk to a Dr. Peard or Purds in Horsham, again referring to a particular pupil. As you know, this boy is on the hepatitis study, and I've just received the results of his liver function tests. He would appear to be developing hepatitis, which is probably associated with an infusion of factor VIII concentrate, haemophil B, on the 15th of February 1976, and then reference is made to hepatitis B being negative, so it's possible that he's developing hepatitis maybe of the B or non-B type. Please could you let me know if he becomes ill, and should you see him, I'd appreciate further blood samples. If he requires admission, I'd be pleased to come to Horsham and see him. So there doesn't appear to be any suggestion there of a change of course or a change of therapy. It's just an identification that through the concentrate being provided to this patient on the study, they appear to be in the process of developing hepatitis. And then if we go to OXUH 303758_006. This is one of the reports produced by Dr. Kirk. This is dated the 20th of April 1976, and it's a report on the autumn term 75 and spring term 76. And there's a discussion of the hepatitis study on page 5. Says this started at the beginning of the autumn term. The conditions for entry and other requirements are recorded elsewhere in the protocol. So this appears to predate some of the other documents. This is suggesting that the start of the study may have predated, I think, some of the other documents we've looked at. But in any event, the boys were restricted to a particular type of factor VIII replacement material. This is shown in Table 6. 17 cases from Oxford were included from November 75. 2 Edinburgh patients joined in February 1976. It's apparent in conducting a survey of this type, it's difficult to ensure the collection of frequent blood samples unless the patients are readily available. Furthermore, limiting patients to particular replacement materials also creates problems because of the overall shortage of factor VIII products. It is inevitable that some patients will receive and have received materials other than their specified product. Nursing and laboratory staff are to be congratulated on the careful and thorough way that specimens have been collected, separated and dispatched to the virus reference laboratory. The work of Dr. Hugh Platt in the Chemical Pathology Department of Basingstoke District Hospital has been invaluable in processing large numbers of liver function tests, which has been accomplished quickly and efficiently. And then if we go further down, it says so far no patients from Newcastle have registered on the study. It's hoped 12 patients restricted to haemophil will be included in the near future. And then this, since the start, 3 of the college boys have contracted hepatitis, and details are then given. The first is a boy who was restricted to cryobilin. The last sentence of that paragraph says provisionally he's been labelled as a case of anicteric non-B hepatitis. The second boy is described as showing clinical and laboratory evidence of hepatitis soon after being entered on the hepatitis study. It says, bottom of the page, this case is interesting in that the probable source of the infective material can be identified. And again, the reference is to particular batches of cryobilin. This was his first exposure to large pool concentrates. And then the third is a patient described as a mild haemophiliac, which doesn't fit with what else we know about pupils at the college, but in any event, it refers to that patient receiving haemophil, said to be at risk of developing hepatitis B and is going to be investigated further in the summer term. And then the next paragraph, apart from these 3 cases of acute hepatitis, a number of boys have permanently elevated liver function tests. At present, work is directed at determining the significance of these findings, for it is important to ascertain whether they're suffering from chronic hepatitis, and if they are, whether this is benign or an aggressive process. 4 boys have had liver scans, which all show mild but very definite abnormalities. It's proposed to do further scans next term on other indicated boys. Regarding the problem with the acute hepatitis cases, it's important to exclude other causes of hepatitis apart from hepatitis B, namely hepatitis A, cytomegalovirus and EB virus. And then there's a reference to hepatitis A. So I think you asked earlier in the week about tests for hepatitis A. This tells us that a suitable test has not yet been devised, which is uniformly satisfactory in relation.
No, the part of the question brought behind the question was a sense that non-A, non-B, has plainly been identified in some of the studies since 1974, if not before.
Yes.
And that suggests that A can be excluded. So there has to be some basis for excluding it.
Yes.
And I had assumed, without actually knowing it, that there was therefore a test. This looks as though there is a test, but it's not a very good one.
That seems to be Dr. Kirk's view. And then it continues with a discussion about the arrangements for the testing of samples. And then, that's the discussion then in this report about the hepatitis study. So we can see as at April 1976, it's identifying 3 boys with hepatitis and a number of boys with permanently elevated liver function tests. If we just finish by going to the next page. Just below the heading home treatment, so the next paragraph down, just draw attention to this. It's not specifically relating to research, as I understand it, but it says, finally, acknowledgement must be made to the Army Blood Supply Depot at Aldershot, under the direction of Colonel John Winnick, for their continued help both in the supply of therapeutic materials in an emergency and the provision of normal plasma for use as standards in the variety of coagulation tests performed at this centre. So it would appear in some respect or another, the Army Blood Supply Depot is providing materials to Treloar's. And if we can then go to page 11, I referred earlier to who was getting what in the hepatitis study, and you can see here where the figures that I referred to are drawn from. So cryoprecipitate, cryobilin, haemophil, prophylate, Lister, Elstree concentrate, and then factor 9. Sorry, it's back. There are, again, a handful of further documents relating to information being provided to parents and or clinicians about participation in the study. So TREL 5064_017 is a sheet of some kind about a particular patient saying the above patient is involved in a national prospective hepatitis study. It is thus very important he receives only factor VIII containing material of one type, in his case, cryoprecipitate. So he's one of the category of boys receiving cryoprecipitate. And that's signed by Dr. Kirk. And then TREL 40250_016. Is a letter September 1975. So again, it demonstrates that there are communications ongoing between Dr. Kirk in relation to the hepatitis study and other clinicians, but less clear as to the extent of parental or patient involvement. Dear Dr. Kirk, thank you for your letter concerning your proposed study of patients with haemophilia. In answer to your queries, we'll certainly find it easy to give the patient cryoprecipitate only when he needs treatment. The blood samples that you require will certainly collect clotted blood samples whenever he has treatment. And then the same question as Dr. Mann had posed, are you going to put the children on prophylactic iron therapy? And then 3, I'll be pleased to notify you if he should develop hepatitis. But again, that doesn't tell us anything about what the pupil or parents knew. And then CBLA 40590. It's an update from Dr. Kirk on the 1st of April 1977 to Dr. McGrath at the National Institute of Biological Standards. Dear David, we've been conducting the hepatitis survey for some 19 months and are almost in a position to have a significant result. All the cases of clinical hepatitis and almost all the cases of asymptomatic hepatitis were confined to the patients restricted to commercial concentrates. There were no significant differences between the cases restricted to haemophil and cryobilin. In the next stage of the study, I'm proposing to restrict patients to either commercial concentrates as a group or cryoprecipitate or Lister concentrate, as I understand that all commercial factor VIII concentrates are being made from North American plasma, including cryobilin. So that issue again about the source of cryobilin donations is there addressed. Would you have any objections to these proposals, or do you think it would still be worthwhile to restrict patients to a particular brand of commercial factor VIII concentrate? So there's an update of the position as at April 1977. Then in October 1977, there's a letter from Dr. Krask to Dr. Arenstam at HHFT 40925_001. At 7th of October 1977, first paragraph refers to the arrangements which I had with Peter Kirk is that we've been testing bloods taken from the boys at intervals over the past 2 years as part of the prospective study of the incidence of hepatitis and abnormal liver function tests associated with different forms of factor VIII therapy. Peter Kirk is now writing up his results. And just pausing there doesn't appear to be any positive evidence of pupils or patients being aware of bloods being tested in this way. And then Dr. Krask says, I'm keen to continue our collaboration. This is for 2 reasons. We're interested in doing more work to try and establish the etiology of the non-B hepatitis we found associated particularly with commercial freeze-dried factor VIII concentrates. 2, I think it will be valuable to take serial serum samples from these boys with the idea of trying new tests, particularly those thought to give a good correlation with chronic liver damage. And then just picking that up in not the next paragraph, but the one below, we're particularly keen to obtain specimens as early as possible from patients in whom hepatitis is suspected. And then the last sentence of that paragraph, in the absence of any symptoms of disease, I would suggest taking a blood specimen once a term from each boy. This will give us pre-infection sera should any hepatitis become evident at a later date. So it would appear a bank of stored samples essentially being built up there from Treloar's pupils, with those samples being sent to the Public Health Laboratory Service under Dr. Krask. Just actually on a separate point, but if we look at the last paragraph, Dr. Krask says, I'll be at the annual meeting of Haemophilia Centre Directors at Oxford on the 24th of October. If you wish, we can talk about this further on that occasion. And of course, it's important to bear in mind that whilst we have the minutes of the various Haemophilia Centre Directors meetings, what they won't capture are all the kinds of exchanges and discussions that might have gone on outside a formal setting during the Haemophilia Centre Directors meetings. And then I think there's just two more documents in relation to the hepatitis study. The first is at HCDO 40544. This is one set of minutes from the Hepatitis Working Party. The date is 14th of December 1977, and Dr. Kirk was a member of the Hepatitis Working Party. And under the heading Investigation of Chronic Hepatitis, Indication for Liver Biopsy, the minutes record as follows. Dr. Kirk opened the discussion by describing the results of the prospective survey on hepatitis carried out at Edinburgh and Alton. 45 boys at Alton, aged between 11 and 16, had been studied. There was a higher proportion of patients treated with freeze-dried products who had consistently abnormal liver enzyme tests compared with the boys treated with cryoprecipitate. 15 of these boys had an SGOT of at least 2.5 times the upper limit of normal for most of the period studied. They were well and had no clinical evidence of chronic liver disease. And then there's reference to palpability of the spleen and liver being enlarged in some cases. 5 boys found to have abnormal BSP tests. No definite correlation with previous factor VIII therapy, though this had yet to be fully investigated. And then the next paragraph, Dr. Kirk continues, 2 other boys with clinical symptoms and signs consistent with chronic active hepatitis. One had hepatitis B after a transfusion of haemophil in 1974. He has evidence of chronic liver disease and is still hepatitis B antigen positive 3 years after his acute attack. The second patient had normal LFTs prior to an acute attack of haemophil-associated non-B hepatitis. He still has abnormal liver function tests. And then there is recorded a discussion of problems associated with the interpretation of abnormal liver function tests and liver disease in haemophiliacs. And then there's a further discussion over the page. I won't go through the detail of it because it goes wider now than the question of the hepatitis studies at Treloar's. But there's a discussion about liver biopsy, discussion about investigation of liver disease, and 3 categories identified of patients with abnormal liver function tests, and then a proposal for investigations and recommendations to the Haemophilia Centre Directors. The last document then is an application for a research grant from Dr. Krask, so it's not directly from Treloar's, but it does involve or include some information about Treloar's. CBLA 40756. It's a letter from Mr. or Ms. Buxton, Principal Medical Officer, to Dr. Maycock, 19th of April 1978, and you'll see it refers to an attached application for a research grant from Dr. Krask. If we go to page 6, we can see Dr. Krask is their recording under the heading, bottom of the page, chronic sequelae, a recent study carried out by members of the Haemophilia Directors Hepatitis Working Party in which groups of haemophiliacs were confined to one type of factor VIII treatment as far as possible, has shown that 15 out of 45 boys at the Lord Mayor Treloar College, Alton, had consistently elevated serum enzyme levels 2.5 times the upper limit of normal for periods of 6 months or more. There was a due association with the use of freeze-dried factor VIII concentrate, etc., etc. Reference to having evidence of chronic active hepatitis 1, hepatitis B. And then the question Dr. Krask poses in the next paragraph is whether these changes are indicative of early liver disease, which in a proportion of patients may be the forerunner of chronic active hepatitis or cirrhosis, and then a reference to non-A, non-B hepatitis. So those are probably the most salient documents relating to the hepatitis studies at Treloar's, but it is clear that the incidence of hepatitis in boys at Treloar's was studied over a prolonged period of time in the 1970s, with then this particular focus under Dr. Kirk on limiting treatment to one type of product and then examining the consequences, and we've seen some of the results that were then reported. I should say, what we don't see is any indication of any change in therapy or change in the approach to treatment following the hepatitis studies. Before I move on to look much more shortly at a handful of the other types of research that were undertaken at Treloar's, there's just one document which takes me back to the prophylactic studies and the question of what information was or wasn't made available to parents or patients. Shamit, could we have, and this will have been sent to you this afternoon, I think, CGRA 301060. Thank you, you're ahead of me. So it's a letter from Dr. Jones at Newcastle, dated the 12th of April 1973. Dear Mr. and Mrs. Longstaff, I'm sorry you couldn't come to the last clinic. I enclosed another appointment. You will have received a letter from Lord Mayor Treloar asking for your permission for Peter to participate in the special trial of regular factor VIII injections. So that suggests that there was a letter directly from Treloar's to parents, at least in this case. Refers to someone else's parents also being asked for their permission. And then we can see Dr. Jones saying this: I saw the reference to other set of parents last week and explained that I was in complete agreement with the trial and that it could do nothing but good for the boys and for other patients. It's been most carefully worked out, was discussed at the last meeting of the Haemophilia Directors in Oxford, and has the support of the Medical Research Council of the UK. I will, of course, be extremely happy to discuss any points that concern you about the trial when I see you, but wonder if you would feel able to sign the acceptance form for Lord Mayor Treloar at this stage. And it refers to the doctors trying to get things organised for the next term. Now, this, because of the date and because of the reference to the involvement of the Medical Research Council, must be a reference to the first trial of prophylaxis, which, of course, involved placebos. And you'll see, sir, there's no reference, at least in this material and in Dr. Jones's approval of the trial, saying it could do nothing but good for the boys and for other patients. There's no reference there to the receipt or use of placebo. Just then going to, as I say, deal very much more shortly with a handful of other types of research that we know were undertaken at Treloar's. So if we look at RLIT 40198, on the right-hand side, and this is a publication in The Lancet in 1980, there's a heading, double-blind controlled trial of 3 dosage regimens in treatment of hemoarthroses in haemophilia A. And this was one of, I think we've said in our written note, 3 studies. It's probably, in fact, 2 studies, 3 reports referring to 2 actual studies, conducted at Treloar's to investigate the optimum dosage of factor VIII required to treat a bleed. As I say, I won't go into the detail of it, but we can see here reference to the double-blind controlled trial in terms of 3 dosage regime. That's written up in 1980, and then there's a further publication at RLIT 5098. But this is probably about the same underlying study. But there is then a second double-blind controlled trial at RLIT 40111. And we can see this is a double-blind controlled trial of 2 dose levels of factor VIII in the treatment of high-risk hemoarthroses in haemophilia A. Again, I'm not going to go through the detail of them, but it's a further evidence of a different types of research being undertaken and trials being undertaken in relation to the pupils at Treloar's. I just want to then look at a handful of documents which show a degree of interaction with parents, some in relation to this, the double-blind controlled trials of 3 or 2 doses. Some may be in relation to other aspects of research or trials at Treloar's. But it gives us a flavour of some of the interaction between Treloar's and parents. TREL 40105_040. So this is a letter from a parent, May 1978, to Dr. Arenstam and Dr. Painter. Thank you for your recent letter concerning the higher dosage of factor VIII. Whilst I agree to the first part of your programme, the higher dosage, I do not feel I can give my permission to your other suggestion concerning the other substance you mention. Before agreeing to anything like this, I would like to know a lot more about this other substance and for it to be tested at length. So I would ask you not to include, and then the patient name redacted, in your programme. So there has clearly been a form of correspondence directly from Treloar's to a parent in relation to what appears to be the trial relating to higher dosages, but perhaps an indication of a lack of sufficient information to enable the parent to feel comfortable giving consent to all aspects of what have been required. Again, there's a letter expressing quite similar concerns from a different parent at TREL 40147_018. A letter, in fact, to the same date, this addressed to Dr. Painter, suggesting agreement that the patient should take part in your first project. So again, there's been a letter referring to 2 projects. If the second project only requires the monitoring of 1 bleed, then this also has our consent. As a matter of interest, we'd be grateful if you would let us know the nature of the other substance and the results you would hope to obtain. So again, some indication that whatever letter has gone out to parents from Treloar's, it's not giving information about what the actual substance is that it's proposed the pupil should be treated with. And then, again, the same month, TREL 5070_027. There's a letter from another parent which says, we agree that if some definitive information could be obtained on the dosages of factor VIII required, that would be helpful. However, we're not happy about our son being included in an investigation conducted as you describe. We are anxious that the total amount of factor VIII he receives should be kept to a minimum, particularly to lessen the risk of his developing antibodies to the material. Over recent holidays, we've found that for most bleeds, if they're treated promptly and with sensible behaviour on his part, 3 240-unit bottles of haemophil are sufficient to arrest the bleeding and avoid a recurrence. For a bleed in a difficult place, or if treatment is delayed, a larger dose is necessary, and the risk of a recurrence is considerable. From what we learn from the pupil, it seems to me that the dose he normally receives at the Treloar Haemophilia Centre is quite high, and we would not wish him to receive a higher dose except in particular circumstances.
Peculiar circumstances.
Except in peculiar circumstances, sorry. As regards his participation in a study of the effects of a substance, again, undefined what that is, which might improve the efficacy of the factor VIII given, we would have no objection. In fact, we're enthusiastic about him doing so. There are a parent expressing particular concerns. Again, it gives rise to the question, and unfortunately we don't have copies of all the correspondence that went out from Treloar's, although we may still locate it. But it raises the question of whether the implications of receiving higher dosages, possible increased risks, had been spelt out to all parents. This is a parent who seems to be reaching that conclusion, as it were, on their own initiative or based on their own knowledge. There is then at TREL 40147_019 a reply from Dr. Painter to one of the letters, which indicates what the other substance is, or provides some other information about the other substance. We're told it is in fact a hormone produced in the body, has the effect of concentrating the urine whenever the intake of blood is reduced. It's been found to raise the factor VIII level in mild haemophiliacs. As far as we can ascertain, no one's tried the effects of using this substance in conjunction with a transfusion of factor VIII in a severe haemophiliac. We intend to try this to see if it might either prolong the effective life of the injected material or perhaps enable a smaller dose to be effective over a given period of time as the larger one. So we see an explanation there, but it might perhaps beg the question of why that explanation was not included in the information that was provided to parents in the first instance. The details of who this letter is addressed to is redacted, but what I can say, and it's interesting to note, is this is actually a letter addressed to a doctor who it appears may also have been a parent. And so an informed parent may have been able to raise questions and get an answer and get information which should perhaps have been included in whatever is provided to parents in the first instance. There are then, I'm not going to go to them, I think, but there are, again, a handful of communications between Treloar's and doctors who are treating haemophilia clinicians about involvement in these studies. Perhaps one worth looking at, TREL 40327_005. Here we have Dr. Arenston writing to Dr. Swinburne. The first paragraph refers to the trial comparing a normal with a high dose for bleeds. And he says, I enclose a copy of a paper based on the identification of the high-risk bleeds for your information. So again, we can see information being provided to treating haemophilia clinicians, but it's not apparent that the same information is being provided to parents. And then a further type of research or that was undertaken at Treloar's is apparent from HHFT 301201_004. So this is an outline protocol produced by Dr. Jones and Dr. Arenston. And we can see that the aim describes the study as forming stage 1 of a proposed investigation into the potential benefits of high purity factor VIII. The results obtained will form the basis of the decision to proceed to stage 2, a trial of factor VIII in the prophylactic management of haemophilia. And then the objective is to compare the in vivo half-life and recovery of high purity factor VIII with that of another commercially available factor VIII concentrate of intermediate purity, haemophil number 2. A little further down the page, under the heading patient numbers, it says there's a minimum number of 12, 2 centres will participate with a minimum number at each centre of 6. Bottom of the page tells us that the products to be used are Armour, factor VIII high purity, and Haemophil, produced by Travenol. If we go over the page, we can see the dose is to be calculated so that the patient's factor VIII level will be raised to 50%. There's then reference to investigations and a range of blood samples. It says the samples will be treated as fresh specimens at each centre, but someone's then written and stored. And then the bottom of the page refers, under the heading Ethics, informed consent will be obtained from all patients who will have the right to refuse or to withdraw consent without prejudice to their routine treatment. The investigators undertake this pilot study on their own responsibility and do not need the agreement of an ethical committee. There is no regulatory implication in the study. Again, what we don't have is any kind of understanding of the information being provided to patients or parents to elicit informed consent. If we go to TREL 5012_113, we can see here a document we've seen now on a number of occasions. So the consent form, which gives no information about what trial is being consented to. It's just a trial as explained by Dr. Arenstam. The reason for referring to it is that if we go over the page, we've got a very slightly different form, where here the agreement is to taking part in a trial of a new factor VIII product, as explained by Dr. Arenstam. It still doesn't say what the product is. But somebody has written on the top, H-life, half-life trial, which would tend to suggest that it may be related to the protocol that we just looked at. And again, if we look at TREL 400108_158, we've got another example of a consent form in this format. So again, someone's handwritten on it, HL half-life trial, and the consent is to taking part in a trial of a new factor VIII product, as explained by Dr. Arenstam. There are some comments at the bottom of the page from the parent saying, very pleased to hear a new type of factor VIII has been manufactured, only hope it proves successful. But again, we can't ascertain from this what information's actually been provided to the patient or their parents. This work was written up at RLIT 40104. I'm not proposing to go through the details of it. We can see it was written up by a number of authors, and it refers to the involvement of both Treloar's and the Royal Victoria Infirmary at Newcastle upon Tyne. It may just be interesting to note at page 6, under the heading Acknowledgements, this work was supported by a grant from Armour Pharmaceutical Company Limited. And if we go to HHFT 301201_003, we can see a letter from Armour to Dr. Jones, dated the 23rd of December 1980, and it would appear from this that Armour have had some considerable involvement in the development of the protocol, and it refers to a discussion in Alton, so presumably at Treloar's. Please find enclosed a copy of a protocol revised according to our discussion in Alton on the 1st of December. And then it refers then to discussion and agreement about various points. The centres taking part will be Newcastle and Alton. Each centre will recruit a minimum number of 6 cases. The study will start in January 1981. There's then an estimate of costs. If we go over the page, agreement that the costs will be met from research funds initially, and then Armour are going to reimburse on receipt of an invoice. We agreed that the Haemophil 2 would be obtained and provided by us, We therefore need to know as a matter of urgency the quantities you and Dr. Aronson calculate to be necessary. So a degree of close involvement, it would appear, from ARMA in that trial, which obviously was seeking to compare an ARMA product with the haemophil product. And then there are just, I think, just a few examples of other forms of treatment that I can refer to, I think probably in about 10, 15 minutes, so it may be worth completing it rather than having a break and coming back.
Yes, well, let's do that then, shall we? But if you begin to think that it's going to take too long,
I will.
Do remember that people might appreciate a break.
Yes. Another area of study was trials of autoplex. The report of that is at RLIT 40110. I think I can just refer to the heading here, the use of an activated factor 9 complex autoplex in the management of haemoarthroses and haemophiliacs with antibodies to factor 8. And we can see there, again, its origin is Treloar Haemophilia Centre. So that's a study resulting in this publication, a study I think carried out probably in 1980, 1981, published in 1982. There was a further study under the auspices of the UKHCDO's Inhibitor Working Party, and it may be worth just looking at that. It's OXUH 447_002. So this is a report of the UK Factor 8 Inhibitor Working Party, October 83. So a subsequent study continuing the trial of autoplex versus factor 8. I'm, again, not proposing to go through the detail of it, but if we go to the second page, we can see in paragraph 3, concern has been expressed as to whether AIDS might be introduced into UK haemophiliacs via the use of Highland factor 8 or autoplex. The chairman of the Working Party has sought clarification from Travenol Laboratories as to whether any of their material is known to have produced this problem in the United States, and it's hoped that an answer to this question will be available at the meeting. There is also, in relation to the UKHCDO study, some evidence of patient information, HHFT 301161. So this is not the solely Treloar's study. This is the UKHCDO's Inhibitor Working Party study. But we can see it's headed patient consent form, and this appears possibly to be a draft of some form of patient information leaflet. If we go to the third page, you'll see that there is then a consent form, a blank standard consent form. There's no evidence which indicates what form of consent, if any, was sought for the first autoplex trial undertaken under the auspices of Treloar's alone in 1980 and 1981. We know there was also a study in relation to Ddavp. There is, again, some evidence of exchanges between Treloar's and parents in relation to that, although the information is relatively limited and there's no patient information leaflet or anything of that kind. If we look at HHFT 301430, we've got some handwritten notes about the involvement of 7 Treloar's patients in a Ddavp trial in the summer of 1982. And that was published at RLIT 40124. and I think we said we can see the influence of DDAVP on the survival of factor VIII in severe haemophiliacs. McClellan-Knight, McClellan-Wassef, Arenston, Treloar's Haemophilia Centre. Again, I'm not going to go to the detail. This is really just try to give an understanding of the very wide range of research work and trials that were undertaken at Treloar's. There is also evidence of a number of students with inhibitors trialling the tolerance-inducing protocol, and we saw reference to that with one of the witnesses earlier this week. We've got a number of examples of individual patients, individual pupils being involved in that process. I won't go through the detail of them because they don't greatly add to the oral evidence you've already heard about that. The one letter that may be worth looking at is a rather later one in time. HHFT 40145_002. So just before I look at this, the trials in relation to the tolerance-inducing protocols for patients with inhibitors in Treloar's appear to have been taking place in the early part of the 1980s. It's perhaps interesting to note in this letter in 1993 from Dr. Wassef to Dr. Worsley at Poole, looking at the paragraph beginning with regard to, the third sentence reads, inducing protocols, so tolerance-inducing protocols, are now coming to the fore again as treaters are encouraged by the safety of materials. So it tends to suggest that they, as it were, perhaps unsurprisingly, fell out of popularity amongst clinicians because of safety concerns. And there is now consideration being given to the reintroduction of them. In fact, there's one of the documents. There is a document in which Dr. Wassef Dr. Arenston expresses a concern about the use of the level of use of factor VIII exposure, but I don't think I have a reference to that. It may be one of the documents we looked at.
You give it, I think it's in the study, TRLE 40173 _070.
Yeah, I'm not sure that that's the right reference, I'm afraid, and I don't seem to have my hard copy. Yes, I think we may have looked at this with one of the witnesses, in fact. If we look down the bottom of the page. Yes, it is that paragraph. Thank you, sir. It's the paragraph beginning, we've given him enough material to continue his protocol through the summer. We did try increasing his exposure to antigen, et cetera, et cetera. It is possibly wrong to continue his exposure to factor VIII at this level, and I'd be interested in your own opinion. And the timing of this letter is July 83. So it's not clear precisely what Dr. Arenston has in mind in writing that, but in a letter from Arenston to Professor Bloom in July 83 might suggest that the underlying concern to which Dr. Arenston is giving a limited voice is about the risk of AIDS. Again, with various examples of consent forms, very much along the lines of the ones we've already looked at. They simply don't explain in the form what it is the parent is consenting to. So we've got multiple other examples, all undated, along the lines we've already looked at. We've got one example, in fact, of a parent refusing to give their consent and indicating that at the bottom of the form. So there are just two further documents then I want to look at today. And they're just indications of some of the interactions between Treloar's and pharmaceutical representatives. So we've seen some indication of that already. IPSN 40331_001 is a letter from Spaywood to Dr. Arenston, July 1980. And it's, I think, just one of a range of communications from Spaywood we've seen in relation to different haemophilia centre directors at the time, but it's an approach to Dr. Arenston talking about porcine product in the second paragraph and making that available, referring to difficulties in terms of financing the research, and then offering savings towards the bottom of the page on the price of Humanate, offering administration kits free of charge, offering delivery within 24 hours, and so on. Top of the next page, Mr. Williams, the director, says, I hope you'll be able to give us some support and use Humanate for part of your treatment programme. We don't have any particular response from Dr. Arenston to that letter. So that might be thought to be a fairly typical approach from what we've seen in relation to other centres, from a pharmaceutical company to a centre director. And then if we go to BAYP 5021_063, this is an internal board meeting of Cutter Laboratories, December 1980. The relevance for present purposes is what's said at page 5. Paragraph 8, it was agreed that full investigation should go into the promises made by Carol Jones and Sidney Pugh to the Alton Centre, where Dr. Arenston had been promised some form of financial support for a research fellowship and had put in a great deal of time and effort in putting forward a representation to the company. However, nothing materialised. It seems that this was causing the Alton Centre to have nothing to do with Cutter whatsoever. It was agreed that this should now be looked into again, with a view to the company being in a position to offer some form of financial support for such a fellowship. We don't presently have any more information about this particular issue, but it does appear to indicate perhaps a relationship between that which a pharmaceutical company does or does not make available to Dr. Arenston at Treloar's and Dr. Arenston's decisions about what products to purchase for the centre. So those are the documentary materials in relation to research that I wanted to draw to the attention of those listening and to you. There are obviously other documents as well, but we hope that gives some indication of the breadth and scope of research that was being undertaken at Treloar's really from the late 60s, 1970 onwards, throughout the 1970s and well into the 1980s. In terms of the question of the significance of this research activity more generally, there may be 3 issues which arise, and I identify them now because I've no doubt that they are matters upon which participants may wish to make submissions in due course. There's, first of all, the issue of patient consent and whether the ethical guidelines and requirements in relation to obtaining informed patient consent were adhered to. And we've seen, obviously, a range of material in that respect, and indeed in relation to a number of the studies, a dearth of material. The second broad issue are the ethical implications of the particular study or trial or research and the ethical implications of an individual pupil's involvement in that research or trial. In other words, were there aspects of that particular piece of research, that particular study, which might have led to the pupil being treated for their haemophilia in a less than desirable or in an unsafe fashion, or in a way that increased the risk of exposure to viral infection? So that's looking at things essentially on a trial-by-trial, piece of research by piece of research basis. And then the third issue is really to stand back and look at the bigger picture of a pattern of research, a pattern of studies over many years in Treloar's, and ask whether the focus on studying what is repeatedly referred to as this unique group who offer unique opportunities for clinical and laboratory observation, whether that focus may have contributed to a mindset on the part of the clinicians involved with the care of pupils at Treloar's, in which they may have lost sight of questions about how properly to treat individuals, how properly to communicate with individuals as patients. And whether there was a mindset of seeing pupils as objects for research and study foremost, rather than as individual patients first and foremost. So I raise those as issues that you may want to consider in due course, and that others may want to make submissions on in due course. There may be a multiplicity of other issues that arise out of the examination of the research undertaken at Treloar's.
Well, presumably your second includes not only the ethical implications of inclusion in a study, but of exclusion from it.
Yes. Yes, so if we take the hepatitis survey and limiting patients to one concentrate, which might be thought to be a better thing than the ordinary treatment regime, the patients who are not being included on it are, by definition, continuing to be exposed to multiple concentrates.
Because I could see there may be an argument that the rationale for doing the study would suggest that should be the norm as opposed to the exception. But that's a matter for submission in due course.
Indeed. So that completes the review of the documentary material for the purposes of this week's hearings.
Yes. Well, that concludes this presentation, is it?
It does, sir. I should say the written note, which refers to many, not all of the documents, but most of the documents that I've drawn attention to in the week, will be published on the inquiry's website probably next week, which will enable all those interested to view it. It's already obviously been made available to legal representatives and core participants, but it will enable everyone who wishes to see what it says.
And looking ahead beyond next week,
we have a break in hearings, not a break in work, but a break in hearings for 3 weeks. And then we resume on, I think it's the 19th of July.
I think it is too.
Is that correct? For what will be a busy 2 weeks. We are anticipating hearing 3 days of evidence from Dr. Diana Wolford, a medical officer within the Department of Health. And then 2 days of evidence from Lord Simon Glenarthur, Minister in key parts in the 1980s.
And that is the week beginning the 19th
That's the
of
week
July.
beginning the 19th. So we are anticipating sitting for 5 days that week. And then in the following week, so the week beginning the 26th, we are sitting, we hope, on the 27th, 28th and 29th to hear the evidence of Lord Kenneth Clarke.
Thank you. So, 19th of July, 10 o'clock.
Thank you, sir.